Secondly, I'd like to talk about new changes to the referral pathways. As you will know, there are various ways of accessing secondary care for your patients who are symptomatic, particularly the 2-week wait referrals. And so after about 3 years of deliberation, NICE have recently updated their guidelines about which patients you should and should not refer through the 2-week wait pathway. The general premise of the changes are to significantly lower the threshold for referral, both in terms of which symptoms to refer and at what age to refer them. So the new referral guidelines stipulate that you should be referring patients on the 2-week wait rule if they're aged 40 and over with unexplained weight loss and abdominal pain, age 50 years and over with unexplained rectal bleeding, and age 60 years and over with an iron deficiency anemia, change in bowel habit, or a positive fecal occult blood test. Another new feature of the NICE guidelines is the introduction of the somewhat controversial use of fecal occult blood tests by GPs. Previously, I've been speaking to GPs about not using fecal occult blood tests, but it seems that the NICE guidelines have put that in, and that's a new feature. The fecal occult blood test, therefore, should be used for patients with relatively low risk symptoms, and they would include patients who are over 50 with unexplained abdominal pain or weight loss, aged over 60 with a change in bowel habit or iron deficiency anemia, or over the age of 60 with an anemia even if it isn't iron deficient. So in other words, pretty much anybody that you as GPs are concerned about, NICE now wants you to refer on the 2-week wait pathway, and that's a significant change from previous guidelines. The reason it's important to lower the threshold for referral is to pick up that one patient per year who you should be seeing. I don't think many GPs refer 30 to 40 patients on the 2-week wait per year, and this is something that we need to be doing in order to diagnose patients earlier. It's not entirely clear at the moment where the funding will come from for referring more patients earlier. However, if we diagnose patients with bowel cancer earlier and at an earlier stage, then the implication of that is those very expensive chemotherapy treatments and palliative care and end-of-life treatments that we currently use for advanced disease, we may not be using so commonly in patients who are diagnosed earlier. And therefore, the funding already exists. It just needs to be moved from the end of a patient's journey to the diagnostics and the early referral at the beginning. So in summary, even though I would accept that secondary care consultants like myself have a problem with capacity in terms of outpatients and endoscopy, it's really important that we encourage GPs to refer more patients in on a 2-week wait. It's only by doing that and lowering the threshold for referral that the excess mortality that we see in England can be rectified.